How would we bring this into your care path? Well, for sure, once you've had a colonoscopy and you've had a diagnosis of ulcerative colitis or Crohn's disease, or you're symptomatic, and we want to understand whether you need to have a colonoscopy in order to get a diagnosis, you would come to the clinic and we would do blood, stools, make sure you don't have an infection, and listen to your symptoms. Then we can do an ultrasound and comprehensively look at your entire bowel. If you don't have a diagnosis yet, and all your bloods, your stool tests are normal, and your bowel ultrasound is normal, then maybe we would take a step back and say, let's try some conservative measures. Let's say alternatively that we can see inflammation on your bowel ultrasound, your fecal calprotectin's up, your CRP is up. We can then expedite your colonoscopy. To get a diagnosis of inflammatory bowel disease, we will always need a colonoscopy because we need tissue to look at under the microscope, so we have histologic evidence of disease. With that, we can then follow you at different intervals to see whether the therapies we implement work. So let's say you get a diagnosis of Crohn's disease in the ileum, we have tissue, we do an ultrasound, we have a baseline set of measures, we start you on effective medical therapy. We would then 3 months or 12 weeks later, follow you up to make sure you're getting better. And the first thing we would do is an ultrasound. We can look at your CRP and your fecal calprotectin for sure, but we want to see whether that wall of the bowel has shrunk in its thickness. We want to see whether the blood flow is improved. We want to see whether the mesentery is less active. Then again at 6 months and potentially at 12 months.